Normal. Ingrown nail, quote unquote, kind of, but with like a skin anomaly. So this area almost looks wart-like. So I'm gonna have to send this out for pathology to review it, because the way the patient keeps cutting this portion off and it keeps growing back the same way. So it's almost coming back like a wart. And then of course, in combination with the nails being fungal, it just makes it even more complicated and more painful. The redness, as you can see on this nail, is right around the proximal nail fold. So that shows me that it's infected, but why is it not infected here? Why isn't it more red here as opposed to here? So we are going to pull off each nail, because this is on both sides, and we're going to look at the other side as well, as long as Jolene can stretch across there. But we're going to pull off both nails today, clean them out nice and good, and then send this out to pathology to make sure it's nothing crazy going on. But this nail this nail is more like an ingrown nail because of this area right here. The nail, you can see it actually digging in. Well, I don't know how clear you can see it, but it's actually digging into the corner here, and that's more of a typical ingrown nail. But again, all this extra skin, just not normal. So I was telling the patient this, and I know I keep saying this thing over and over again, but you know, we see these things every day, 1,000 times a day. And so when something abnormal comes up, I'm honest. I tell you, because I don't like surprises. So, but what we also do is we do our due diligence and do the right thing, which is send it to path. Send it to path right away, make sure it's nothing crazy. And then once we clear anything crazy, then we just move on with our lives and treat whatever it is. Because if they say it's a wart, we treat the wart. If they say it's an ingrown or an infection with the wart, then we treat both of that. So it's not any difference for me. So we're just gonna check if he's numb. Any pain when I push here?
No.
Good, perfect. So again, this is just an avulsion. We're not killing the nail. I'm just loosening it up so it's easier. There we go. And this kind of looks like a granuloma now that I keep looking at it, but it's okay. I don't know if you want to keep switching back and forth, but. And then to add to the history, and again, we're keeping everything confidential, but the patient was in the military and had undergone a form of trench foot, which is basically a long exposure and subsequent infection from long exposure to moist environments. Mostly, basically, your foot's in a trench of water for days on end, and your foot does not like doing that. It's a rule in general that too much of anything is bad. So too much water to the feet, yeah, you're gonna get an infection. The most common water infection for feet is Pseudomonas. Pseudomonas is when your nail actually turns green, or whatever is infected oozes out green pus, and it just is not a great disease to have. But it is treatable. Luckily, the patient didn't suffer any gangrenous changes to the foot, so that's good. But still, it's very risky because you just can't help it. You can't get out of the environment because you're in country, right? So that's where you're at. All right. This one. When I got a closer look, now that I took the nail out, I'm pretty sure it's a granuloma, which is something that forms after an infection, okay? So basically, it's possible that you're getting chronic infections all the time and getting this granuloma, which is basically like a hypertrophy of the skin fold, okay? So the skin gets really upset and angry, and then it gets inflamed, and then it becomes that. Usually you see it in pediatric patients a lot with ingrown toenails, but not so much adults. Why, I don't even know why, to be honest, but it is a thing.
Just extra skin growing?
Yeah, it's infected / really upset skin. Okay, for lack of a better phrase. Let's see here. I'm gonna clean this area a little bit better. And then we're probably gonna need some Adaptic and yep, okay, perfect. And then we're gonna need a silver nitrate stick, because that's gonna bleed like crazy. So if you want to pause, now we gotta do the right one. There we go, nice and clean. And here is the hypertrophic tissue, which is not as bad as the other side.
Definitely. The left one developed first, and then the right one.
Yeah. So it's been around longer.
Yes.
And it's tough because, again, my son was born with these exact toes, except his toes that curl are the third one. So his curl, and this is what happens. It curls underneath the other toe, and you almost develop like a augmented shape to the toe, right? Because now it's flattened out on the one side because it's curled under. So I don't know if you guys can appreciate this, but this side of the toe is flat because that's how he walks on it. He doesn't walk on the pulp of it like the other toes. And that's what happens when you have a curry hammer toe. Of course, this is probably congenital. At least that's what it looks like. Your foot's been like this all your life, right?
Yes.
Yeah. So it looks like a congenital. The hammer toe you usually see is, where the digits actually contracted. This one is just kind of curved to it because of the fact that he was born with it. So what happens? And this is, my son has the exact same thing. And I could have been proactive and taped it as a kid, but who wants to tape an infant's toe every single day? And then, have them possibly take the tape off in the middle of the night and choke on it, and nobody really wants that risk. So we opted not to treat it. And if he needs to get some kind of surgery later for it, God forbid, then he'll get it done. But he's not going to have anything done now because he's 6. There we go. Okay. There we go. Okay, so that's pretty much it. The rest of it is just a dressing, so it's really nothing to see. I can't stress this enough. Whenever you have an avulsion done, make sure your doctor puts a daptic on it or a non-adherent gauze, because when you take off the dressing, you do not want the dressing sticking to your toe when the numbness wears off, because otherwise you're going to be in excruciating pain. If your doctor did forget, or even with the adaptic it's getting stuck, then call the office that you're at, or call our office or whatever if you're here, and we will give you instructions over the phone on what to do. And basically it's usually soaking the toe to the point where the gauze is actually loose enough to be pulled off slowly, something along those lines. It's going to be basically involving soaking, so that becomes really pliable and wet, and then it's easy to take off. So this is Dr. Cruz, bilateral 4th toenail avulsions. Pretty uneventful. We're going to send that stuff for a biopsy just to make sure, since it's been chronic over how many years?
I would say several months.
Several months, okay.
For sure.
So several months of chronic ingrowns, and therefore developing this type of granuloma / who knows. So we'll check, and then we'll check back in with you guys, let you know what the result is. Of course, we'll tell the patient first, so he'll know and not have to worry. But I think it's going to be okay. So we'll double check the biopsy when it comes in. This is Dr. Cruz for Healthy Feet Podiatry. Subscribe to our YouTube channel, subscribe to our Instagram at Healthy Feet Podiatry. My personal Instagram is